when did you know that you wanted to become a physical therapist?
Yeah, so I probably have a very similar story to most physical therapists. I actually sit on the admissions committee for High Point University, so I get to read a lot of the incoming essays, and they all read almost identically to my essay coming into PT school, which was I got injured, I had physical therapy, and I thought it was great, and then I chose that career path. So for me, I broke my second MCP through the growth plate on my right hand while playing football. And I needed to end up getting some surgery to repair it to make sure the finger would still continue to grow. And I had a great occupational therapist at the time out of Berk's Hand Therapy. And I didn't know that he was an OT. The surgeons always called it PT and he never corrected them. So I thought, oh, PT, this seems great. And it wasn't until years later that I understood the difference, but that's how I got launched.
That's great. And so this kind of led you off into going to PT school, of course, but why did you choose to go towards Baylor University and going into the field with like the Air Force, so to speak?
I was actually already in the military. So I joined the Marine Corps at 18 years old. And then I ended up switching to the Air Force. They offered me a scholarship for a commission. So I switched to the Air Force. So when I applied to U.S. Army Baylor, that was really my only choice. I was under a military contract. The military only has one pathway to a DPT. That was through Army Baylor. So my first year, and on top of that, the Air Force only accepts 2 people per year into that position. So my first year, I applied, and I was the number 3 applicant. So I was on the wait list, and I ended up wait listing off that year. So the year came and went, and I didn't get picked up. So then I had to apply my second year, and then I was one of 2 people that got accepted that year. So for me, there really wasn't much of a choice. But at that point, when I was applying, I loved the military. I knew I was going to be a PT. One way or the other, I was going to be a PT. But I wanted to do it in the military. And I think that was also part of my essay, is that, hey, this is where I want to be. I want to do this in uniform, but if I can't do it in uniform, then I'll find a different path to PT.
Right. And so you got injured when you were in the military, and then that's when you wanted to become a physical therapist, or was like earlier and then you...
Oh, no, I got injured when I was in the 8th grade. So
Eighth grade,
it was
gotcha.
through the growth plate. And then, it just took it took a little bit of a circuitous path to get to PT. I actually started off as a cook in the Marine Corps, and then I switched to being a communications officer in the Air Force. But my intention was always physical therapy. It was just a matter of how to get there. It was a little bit less straight line than some other people.
Yeah. So what were some of the barriers during that process? I mean, it can be daunting early on when you're trying to apply for PT school. And I guess maybe if you can reminisce on some of the times that you were, like that time that you're trying to apply and stuff, what were some of the difficulties of trying to get in?
Yeah, well, I think there are a couple of challenges. I mean, I think I got into schools right out of high school. I mean, I had good grades and good SATs out of high school, but I think that the challenge we had was financial. We just didn't get enough financial support in order for us to be able for me to go to college. So I ended up joining Marines primarily for college assistance, and then I used the GI Bill to get me into school. And at that time, this is back, I graduated high school in 97. I attended school in 98. And at that time, physical therapy was still a bachelor's program in some schools, but we were transitioning. By 2003, we were a master's program. So that's the transition time that was happening. Everything was going to a master's, but it was kind of new. And it was also, with that, we had a lot of the combined program. So it was like, 3 years here at your undergrad and then 3 years in a doctoral program. They had a lot of these, 4+2 or 3+3 programs. And then when I went to my undergrad, with the understanding that there was I think it was a 3+3 program with some other university. And, but it was just never really well managed. When you got there, they didn't really talk to you a whole lot about that. I mean, it wasn't like they had a lot of people that were doing those pathways. So I think the route was a little bit more ambiguous, and maybe if I was more of an advocate as far as some of the advising I got, I think that might have been better, but it's hard. You don't know what you don't know what you don't know at the time, you know? So,
Yeah.
so then once I graduated and I was active duty in the military, then at that point, there really weren't a whole lot of other pathways other than Army Baylor. But I'm really glad I went to Army Baylor. I think it was exactly what I needed.
Yeah. So with the PT school, normally, you go on clinical rotations. And I guess, what is it like with Baylor? Do you guys do clinical rotations just the same as normal PT school, or how does that work?
Yeah, so we do clinical rotations, but I think it's probably more backloaded than it might be in some other programs. Potentially, we did have two that occurred during our curriculum. Now, again, we're talking now 2007, so I'm not sure if it's still the same way, but we did two rotations during our time there, and then we had a 9-month terminal affiliation that happened, and then most of those are happening at military facilities, whether it be VA or military. I mean, there are some that are happening in the civilian sector, but most of them are happening at military facilities. So one of my affiliations was at Audie Murphy VA in San Antonio, and then my long-term affill was at Travis Air Force Base in California. And then I had one other short-term affill that was in Southern Baptist, which was a local civilian hospital in San Antonio.
Great. And so you went through Baylor, you did all these clinical residencies and now are clinical affiliations, and you graduate with your doctor of physical therapy. I guess what's next with you in the Air Force?
Yeah, so I graduated in 2007 with my DPT while I was at Travis Air Force Base. So for the first 2 years, I continued on as a staff PT at Travis Air Force Base. But I always knew that there was going to be a next step. And I think that that's one thing that I would encourage people, if there's any students listening to this, you've worked so hard to get to where you are in your DPT program. And, you probably started in junior high, high school, you got good grades, then you went through college, and now you're in your doctorate program. And one thing I would encourage people is to think about what is next, because when you graduate and now you're a DPT at 25, 27, whatever, you shouldn't just stop. You should keep going. So for me, once I graduated, I already had my eyes on whatever was next. So for me, I applied to a fellowship out at Kaiser Permanente. That's where I went 2 years thereafter. And I actually took my board certification exam right before I went to Kaiser Permanente, and I got my OCS certification. So that's another thing too. I encourage people to, go get their board certification. I mean, it's and to do it quick and to do it early. I mean, you just, if you're graduating your DPT program, you just got the latest and greatest evidence that's out there from your professors, wherever you were. Go take your board cert. You're going to be eligible for it 2 years after, and that will supercharge your career. And, I'll hear people tell me, oh, well, it costs too much money. It's, if you're an APTA member, it's $1,300. Well, shoot, man, you just spent $200,000 on your education. I mean, by comparison, that's like buying a house, but not buying the doorknobs, like go spend your $1,300 and get recognized as the expert that you are. And once that happens, that opens up doorways to so many other things, to academia, to research, to, being a peer reviewer, to a million other things. So that is really a gateway to supercharge your career. So the sooner you can get a board certification, the better off you are.
Yeah. And that money's you're going to spend that money on continuing education anyway. So you might as well get the best of the best by getting a cert in the process versus just kind of like throwing darts at a dartboard and hoping that the education that you get is something that's going to be clinically appropriate.
Yeah, that's a really good point. If you actually look the ABPTS website, the American Board of Physical Therapy Specialties, their website actually has statistics of what all shakes out from board certs. So the majority of people get reimbursement from their employer for their board certification. So most employers are going to have some level of continuing education stipend that you're allowed to use each year. So a lot of them will allow you to just kind of transition that to your board certification. So the majority of employers are reimbursing for that. And then the majority of people do get financial incentives after getting it. So to hear things, people talk about, oh, well, it's not a good investment. Well, shoot, it actually is. I mean, people are they're getting raises for it. Now, not everybody gets a raise. And a lot of times you'll need to, change your position in order to get that raise. So if you're working at ABC physical therapy, that's a fictional, if there's actually an ABC physical therapy out there, I'm not trying to do that, but XYZ physical therapy. And you're working there on Friday, and on Saturday you're certified and you come back on Monday. I mean, there might not be an incentive for them to pay you more, but now you go to the next position and now you're more desirable, and they're gonna pay you more to land you. So
100%. And we're talking about career strategy, and I guess I saw that you also got deployed to Afghanistan, and I guess where did that fall into place for your plan after PT school?
Yeah, so that happened. I was a reasonably new graduate. I deployed in the fall of 2008. So I was out of school for a year when I went to Afghanistan. So I was going out of Travis Air Force Base. So I showed up to Afghanistan. I'm the clinic chief. 1 year outside of school, I'm supervising 2 PTAs. I'm the only physical therapist at the time, and on top of it, in Afghanistan, you're kind of alone. You're on an island. There was no other PTs that I could talk to. My PT colleagues back in the States were, on a 12-hour time difference. So when I was awake and I needed help with the patient, they were all asleep. So I think that really became an interesting flashpoint in my career, just understanding like, wow, like I need to be able to stand on my own, as a doctorally trained musculoskeletal expert, and be able to handle, everything that walks through my door.
Sure.
And, the responsibilities that we had there. So when I got there, our family practice was getting slammed. So primary care was getting slammed. They had a lot of patients. We had a lot of inpatients as well. So I was with that, we had what's called sick calls. So essentially patients would come in, they would say they're here for whatever condition. I would go over to family practice and I would go through the list of people. And if they were there for back pain or knee pain or shoulder pain or whatever else, I would pluck them off the list. I would see them in physical therapy, and then I was essentially acting as a family practice or primary care provider in that way. So I would prescribe them the medications if need be. I would order them the imaging if need be. I would take care of their entire case. And with that, I was averaging 25 patients a day. For me solely, that doesn't include the patients we were supervising from the PTA standpoint. And of those 25 patients a day, we averaged 20 new evals a day and 5 follow-ups a day. So the majority of patients that we saw, we would only ever see once. So we had to make sure that if they needed medications, they had medications. If they needed a brace, if they needed, any kind of equipment, if they needed imaging, if they needed to not be in theater for whatever reason. We had a couple of people that came in with broken legs. Well, you can't stay in theater with broken legs. You can't run for cover and protect yourself. So, so I was making all of those decisions about whether they would stay in theater or not. And, and if they left theater, I was responsible for getting the patient admitted so that they could, transfer out. So it was a busy time. We would start seeing patients around 6 a.m. and I would just continue to see patients until there were no more patients left. So the average workday was about 12 hours, but that was 12 hours of patient care. And then I would usually write notes afterwards, because again, you have 20 evals and 5 follow-ups a day. I would just write notes until I fell asleep at 10, 11 o'clock. I'd fall asleep on my plinth in my office. So the same place I was evaluating patients, I would just sleep on my plinth. I'd wake up in the morning and there was a shower right beside my office. I'd hop in the shower, and frankly, there were days that I didn't leave, a 20 square foot area, just because everything was right there where I needed it. So, so it was exciting times.
I was gonna say any PT out there who's saying that they're burnt out, listen to the story and just reevaluate how how you feel about your clinic.
Yeah.
And
Yeah, I don't think that's sustainable long term. I think that that's I did that for my deployment, but I don't think anybody could do that for a long term. I think in reality, I think you know physical therapists should really be in an outpatient setting. They should really be capped at about 14 patients a day. I hear there are clinics out there that are doing 25 patients a day, and physical therapists are doing a lot of group physical therapy, and I think at that point we become more of a modality, more of a treatment approach, more than the doctorally trained musculoskeletal experts that we are. I mean, if you look at, who are our comparables? You might want to compare us to primary care, or orthopedics or whatever else. So MDs, physicians, PAs, NPs, and none of them are seeing group appointments, and sure, are they seeing 25 patients a day? Yeah, but they're not doing what we're doing. So,
right.
14 patients a day seems like a reasonable cap. Anything more than that, then you really start to have to question, are we actually doing doctoral work, or are we at that point just a modality?
Absolutely. And, we could go on the reasons for that and all that, but definitely a rabbit hole for another time. But it blows my mind that you were making all those calls at such an early point in your career with medications, imaging. I mean, managing that many patients is just insane. And did Baylor prepare you medication wise? And also, for people that don't know, physical therapists aren't allowed to prescribe medications or provide or like schedule for imaging normally. Now in the government or within the field of like the Air Force or the military, you are allowed to do so. And so I guess, did Baylor prepare you for those situations with medication prescription as well as imaging? And I guess, how did you continue to use that moving forward after being deployed?
Yeah. So what I would say is every program in the nation is preparing their students for those decisions. You look at the Air Force physical therapist population, and like mentioned before, only 2 of them a year are going through Army Baylor, but the Air Force is bringing on, 20, 30 PTs in any given year. So the majority of physical therapists the Air Force is bringing on are civilian trained. And these are people that are expected to, utilize these skills, and they do just fine. And I think what it is, every program in the nation teaches about diagnostic imaging, and they're mandated to. They must do it. It's obligatory, or they can't have accreditation. It's a requirement through CAPT. But what happens is they'll get this training, and then they leave school, and then they can't use the training because it's prohibited in their state or whatever else. So those skills wane over time, right? And I look at, the graduates that are coming out now. The DPT degree is a very broad degree. When you come out, you can be a physical therapist in a neuro setting, or a pediatric setting, or orthopedics, or acute care, or any other number of settings. That's the way the license is set up. You get a broad degree. But over time, some of those skills are going to wane. And as those skills wane, you're going to get deeper in other skills. So for instance, right now, I'm very strong in outpatient orthopedics. I'm reasonably decent in acute care because I've worked in those settings. But if you stuck me in a pediatric setting, I would do probably far worse than a new grad. So I think that, being able to utilize those skills is really what makes people great. I don't think Army Baylor has any secret sauce to it. I think it's just more or less being able to practice in that capacity. In the military, we can do prescriptions, but it's limited. So it's primarily NSAIDs, so Motrin, Celebrex, things like that. We can do Tylenol, and then we can do any of the muscle relaxants. So it's a limited formulary. We're not putting people on narcotics or anything like that. We're not giving people their medications for hypertension or diabetes. And then on top of it, in the military, especially in deployed setting, you're seeing primarily a young active population. So you're seeing people that are 18 to 40 years old and probably don't have a whole lot of other pharmaceuticals that they're on, right? So I think it would be a whole lot different if I was seeing primarily a 65-year-old population that, there's polypharmacy going on. And at that point, frankly, primary care providers, physicians, MDs, PAs, NPs, they are stronger than we are at prescribing medicine. And I don't think anybody would counter that.
Mm-hmm.
However, in, select cases, this is somebody that's 22 years old and rolled their ankle, and they don't have any other pharmaceuticals going on. Can I safely prescribe them Motrin, assuming they have no other medical conditions? Yeah, and that's essentially how it shakes out.
And do you see the field of physical therapy going the direction of that we're able to do that? And I guess how do we draw the line of like when, like where we can prescribe? Because you're kind of saying like if they're young, then we can prescribe medications, it's kind of easy, but when they get older, it kind of gets more complicated with other medications. So do you think moving forward, is it going to be like, okay, the cutoff is like at 40, or
Sure.
do you think we're going to have to learn more as physical therapists to understand like how drugs interact and so forth?
Well, I think that's a complex question, right? So first of all, I think as far as physical therapists ordering pharmaceuticals in the United States, I think we are decades away from that. I don't think that's close. I know they're ordering it in the military. I know they're ordering it in, they have a select formulary, I believe, in Great Britain. But I think where we are as physical therapists in the United States, I think we're decades away. I don't think it's going to happen in my lifetime. But then, determining, when we're able to do that or not, I don't think that's a question for the legislator, for the boards. I think, if we do get the autonomy to prescribe a limited formulary, I think at that point it comes into more of a personal scope. So I think people have a hard time understanding the difference between professional scope, jurisdictional scope, and their personal scope. And if you actually, if the listeners want to look up on apta.org, they can actually look up the description of it from a House of Delegates document that's on the APTA website. So, but essentially the professional scope, right? The scope of a physical therapist includes things like ordering imaging. Now, that may or may not be in your jurisdictional scope. So what is jurisdictional scope? That is whatever decides wherever you're working, whether or not you can do something. So for instance, in 9 states now, they have the ability to refer patients for imaging. So some of them people are more familiar with. Those are the states that have it in their actual practice act. That is North Dakota, Rhode Island, Wisconsin, and Utah can all refer for imaging based on the practice act. Colorado has it through their board rules. And then Maryland and DC, I think both have it through board decisions. And my understanding is New Jersey and Pennsylvania have it through silence in practice act. So essentially, there's nothing prohibiting them from referring for imaging, and therefore some healthcare organizations are using that to capitalize and expand physical therapist scope that way. So, but let's say within that jurisdictional scope, let's say you're outside of one of those 9 states, then it is within our professional scope to refer for imaging, but it might not be in your jurisdictional scope. And then we get to our personal scope, right? So I work in North Carolina. It is within our professional scope in physical therapy to dry needle patients. In North Carolina, it is within our jurisdictional scope to dry needle patients. However, I've never been trained on dry needling. It is not within my personal scope to dry needle patients. So I think that comes down to what people are comfortable with, right? Similarly to spinal manipulation. I am comfortable with spinal manipulation, but I'm not going to apply spinal manipulation to all patients at all times. There are going to be times I'm going to be uncomfortable with that for whatever reason, for their presentation or various other factors, and I might not do that. And I think that would be the same way with prescribing medications, is that some PTs might not be comfortable with it, just like some PTs aren't comfortable with dry needling, and that's fine. Some PTs might be comfortable with it in some patients, but not comfortable with it in more complex patients. And I think that's reasonable as well.
Yeah, I agree. And, we're talking about utilization of these modalities or tools that we can use to help with diagnosis and treatment. The use for imaging can be broad. And I guess when we think about using imaging, should we be imaging every patient, or should it be very case specific on whether or not we should be using imaging or not?
Oh, yeah. I mean, certainly we shouldn't be imaging every patient. So some of the arguments that are out there against imaging talk about things like, so much imaging is overutilized, right? And if you actually look at the research, people are absolutely spot on. Imaging is overutilized. However, if you look deeper into the research, right? And if you look at the way the research studies are set up, the research studies were set up to look at how images were utilized, right? But a lot of those early studies weren't set up to look at when imaging wasn't utilized. So the only outcome that could ever come of that study was imaging is overutilized, because they never looked at cases where imaging wasn't used. So it was kind of a biased study. Now, some research is looking more into the other end. So there was an interesting article from Jenkins et al. In, I want to say 2018 out of Spine Journal. And they looked at both sides of the coin. And essentially what they found is in patients that imaging was ordered, I want to say something like 66% of images that were ordered were unnecessary and not appropriate as compared to the American College of Radiation appropriateness criteria. But then they looked at patients with significant red flag findings that need imaging. And they found something like the stats are a little bit unclear, but similarly, 2/3 of them were not getting imaging that they needed. So essentially, we have patients getting imaging that don't need it. And then we have patients that need imaging that aren't getting it. So the true answer to this is not imaging is overutilized. The true answer is imaging is being ordered reasonably arbitrarily and not consistent with evidence-based practice. And if you actually look at the research that's out there, it consistently shows that primary care providers are not using imaging consistent with evidence-based guidelines. But then when you start looking at how we're using it in physical therapy, and you look at the Keel et al. Study and the Moore et al. Study, at the Crowell et al. Study, physical therapists are utilizing it much more consistently with evidence-based guidelines. So in people that are arguing about the overutilization of imaging, right, the don't order on every patient, people tend to attack the modality, right? They tend to attack the tool of imaging. And what we should instead be saying is, don't say imaging is bad. Say imaging is being used improperly, and therefore that is an argument for the imaging responsibility to be shifted onto the experts, onto us, who know when to employ this, as demonstrated by the evidence, know how to talk to patients about these things, and again, get away from attacking the tool and instead identify that it's not the tool that's bad, it's the way the tool is being implemented, and shift that responsibility to the people that know how to use it.
Yeah, no, I completely agree. And I think, do you think it's just because that physical therapists are able to provide a orthopedic assessment very thoroughly and they're able to kind of rule in and rule out, versus perhaps the primary doc who may not have all the tools necessary to figure out whether or not they should be using it appropriately? Or do you feel like primary care is just doing this broad brush stroke where they're just like, just give them an image and see what happens?
Well, I think there's a couple of challenges, and I want it to be understood that I am not bad-mouthing primary care.
Right.
Primary care is the best at the world at what they do. What they're doing every day, they're the best in the world at what they do. But I also think that we're the best in the world at what we do, right? So primary care has a couple of challenges. So if you actually look at the research, less than 5 minutes of the day is actually spent with patients in primary care. And I think we've all experienced that. The doc comes in, they're there very briefly. A lot of times there is no evaluation at all. They don't touch us. They don't look at us. They might look at the screen. They come up with a plan without doing any kind of evaluation at all. And a lot of that has to do with the restrictions within the system and what they're able to do. So, they have a patient at, 130 with uncontrolled diabetes, and then that 140 patient or the 145 patient has low back pain. And which one are they going to spend, more time with? They have a patient at 2:00 with chest pain, and they have a patient at 2:15 with an ankle sprain. Who are they going to spend more time with? And So it's really, and when you look at the training as well, research is showing that 30% of physicians report receiving no musculoskeletal training at all, none.
Mm.
There's a study out there that shows that nurse practitioners get less than 10 hours on average training in musculoskeletal care. So, and again, that's not a ding on physicians or nurse practitioners. They are the best at what they do, but they don't know a lot about musculoskeletal care. So because they don't know, I think these images happen from a lack of understanding of what is actually going on. So I think if there was an ability to shift that responsibility and for them to say, hey, listen, I don't know whether you need an MRI today or not, but I'm going to send you to physical therapy and they're the experts at this and they can make that determination. But because of the way the system is set up right now, they can't shift that responsibility to us. So the responsibility is in the hands of people that just don't have the training to pull it off.
And how do we shift towards that perspective, or at least that idea that seeing a physical therapist first?
Well, I think that's what we're going through now, right?
Yeah.
So, I think that the vision of getting physical therapy to a doctor of profession to be able to fill some of the voids in the healthcare system was an important one. I hear a lot of people complain about that shift. They'll say things like, that was a money grab from the education side, which is ridiculous because the universities didn't decide that. That was CAPTE, as driven by the APTA. And CAPTE and the APTA aren't making any additional money off of that. Or they'll say things like, well, it hasn't returned into reimbursement yet. Well, I mean, we're early on in this process. I mean, the very first year that every program was at the DPT level was 2015. And the very first year that all programs graduated nothing but TPTs was 2017. So we're very early on in this transition. So to say that, it's 2021 now, and oh, by the way, we had, COVID for the last 2 years. So to say that between 2017 and 2019, we haven't seen changes in reimbursement yet. Well, shoot, guys, like give us a little bit of time,
Right,
like let the process work. So essentially, we switched to the DPT and we're using that to leverage expanding our scope. And that's another thing I'll hear too, is that, there hasn't been any return on the DPT. Well, if you look, it's really easy to dispel that. In Wisconsin, they were able to use the DPT to get imaging skills, and the DPT is specifically listed within the Practice Act for imaging. So that certainly has been a huge bargaining chip. So in the last number of years, we've gotten 9 different states with imaging skills. We have direct access in all 51 states, 50 states plus DC, to varying degrees. I know some have less ability for that than others. And I think we're continuing to see these gains expand. And I think once we get imaging across the nation, I think our role is going to dramatically change. Until we get imaging, we're always going to be a modality. But once we get imaging, now we're going to be on the same playing field as the other medical professionals in the field. And that's going to change our roles and who we are in healthcare practice.
Yeah. And for those that don't know, we're kind of painting this picture about the field of physical therapy, and that, before a lot of physical therapists started, like earlier, before 2000, physical therapy was just a bachelor's degree. And then I forgot what year it was, like 2007, there's master's. And then now, like you said, in 2015 or 2017, rather, everyone who graduated from physical therapy school was a doctorate of physical therapy. And by providing that we are doctors and we are educated in orthopedics in a way that we are able to do things such as imaging, it allows for the legislature and insurance companies to believe that, hey, like these guys know what they're doing and we should be able to compensate them for their services. And this is kind of this big struggle, and these, especially more recently, where we're really trying to push for and be advocates for our own profession and what we're able to do. And I think it's great, because like, even for me, I had a patient recently who I saw her for her shoulder, and she was seen by a primary and she got seen by an ortho, and the primary said it was something wrong with her neck. And then the ortho doc said it was something, she had like just tendonitis. And when I eval'd her shoulder, it wasn't, not that it wasn't adding up. It's just, there was something more going on than just like tendonitis. And so she finally got an image and she tore half of her rotator cuff. And so if I had not told her that you literally tore half of your rotator cuff, that perhaps, if we went through the typical tendonitis pathway and nothing was getting better, it's like, well, what's going on? I don't understand. And so, having that ability to understand what's going on and keep pushing and saying, hey, like, we know what we're doing is really important.
Well, I think that's, the case that you just demonstrated is the important thing with that as well is when you have a tendon or a muscle tear to that degree, a full thickness. When you think about the surgery that happens with that, they go in and they reattach the muscle or the tendon. So the sooner we're able to identify that, and the sooner we're able to get them into a surgical consult, and ultimately, the surgeon decides with the patient. It's an informed consent thing, right? We should allow the patient to get informed on what their options are, and then the patient should ultimately make that decision. It shouldn't be on us as physical therapists in those cases, in a massive full thickness rotator cuff tear. It shouldn't be our role to keep them away from getting information from a surgeon. We should be able to send them to the surgeon and say, go see what they have to say, and then ultimately make the decision. If you want to stay with me, great. If you want to go get surgery, that's fine too. I'm going to support you either way. It's the patient's journey. It's not our journey, right? So, but the deal is, if they go on to get surgery, they're going to grab that muscle and stretch it to reattach it. So the sooner we get them in there, and the less time for that muscle to contract and scar down, the looser that's going to be, the greater postoperative range of motion you're going to get, and the better outcomes you're going to get. Right. So, I'm seeing these things about, well, maybe we should manage Achilles ruptures conservatively. And I'm like, wow, like, I don't know that I would want my family to do that. Like, because the deal is, if they go about conservative management of that Achilles rupture, and if it doesn't work after 3 months, well, probably too late to have a successful surgery at that time. You know what I mean? Like, at that point you have, the muscle wasting, the scarring down, and the contractures, and actually getting a reattached Achilles with any kind of functional mobility is unlikely.
Yeah, for sure. And with imaging, I guess, how has this been, and you're such an advocate for imaging and pushing the field of physical therapy, how has this motivated your research? Because you've delved deep into the field of research, and I guess, how does this motivate you to conduct research?
Yeah, so I think it's a great question. So what I would tell people is, I think it's important for clinicians to understand that they can contribute to the research. I had 18 publications as a primary clinician, and they were almost exclusively case studies and case vignettes. And as clinicians, we see incredible patients every day, incredible cases, unusual cases. And so as a clinician, I was essentially, I would see a patient at 10 o'clock and they would come in with something atypical. And I would have to start, looking into PubMed during lunch to kind of figure out, hey, what, this is a condition I haven't seen before. This is a presentation. What am I missing? I start digging into PubMed, and then, after a bit, I realized, wow, like, I did a lip review during lunch out of necessity for this patient. And at this point, I may be just by default one of the leading experts in physical therapy on whatever this condition is, because I needed to be, because of this patient. So, at that point, you've already done all the hard work. You've already seen the patient. You've already treated them. You already have an outcome. You've already managed their case. You've already done the lip review to kind of figure out what's going on to even get that far. At that point, it's probably worthwhile to go ahead and write it up. And I think the one thing, as I get further along in my career, because coming out of school, we always learned that, case studies are the lowest form of evidence. That RCTs and systematic reviews and meta-analyses, those are the only things that really matter. And the further I get in my career, the more I realize, case studies are really the only thing I learn anything from. When I'm going to the research, a lot of times what I'm looking for is case studies, because the deal is RCTs and systematic reviews, they teach you how to get 80% of people better. Well, I'm already getting 80% of people better. By the time I'm getting to the research, I'm not looking at the 80%. I'm looking at the 1%, the 2%, the 5%. I'm looking for these unusual cases. I'm looking for well, most people would get better with whatever treatment this person didn't. Now I'm looking for those outlier numbers, and where are those? Well, those are in the case studies. From a clinical standpoint, case studies are incredibly worthwhile. And what I would also say is, as a researcher and as a now an academic, I don't really have the bandwidth to be doing a lot of case studies right now. I'm not seeing that many patients. So case studies are truly where clinicians can contribute. So that's where I started, is just, I would have these unusual cases, I write it up. And then for me, going through that process, I would learn so much and I would grow so much as a clinician, because I would go through and I would write these things up and I would send them off, and I would get these great questions from reviewers that made me think more about the case, and I'd have to dig a little bit deeper and learn more about the condition. And so every time I wrote one of these case studies, I grew as a clinician as well. So I think that's important. And and the further along I've gone, the further I realized, well, now I can start doing things that are a little bit grander in scheme, in order to really try to impact physical therapy advocacy and legislation when it comes to imaging. So we're doing a study right now. We just did the data analysis on it a couple of days ago, and your listeners will be the first to hear. But essentially, our study found that we looked at imaging skills and how physical therapists are using imaging skills currently. And we sent it out nationwide. We ended up getting 5,895 subjects in this survey, wow, which is an astonishingly large response. And essentially what we found is that imaging is being utilized primarily in outpatient orthopedic clinics and sports clinics, which is, I think there's no surprise there. We also found that doctorally trained physical therapists are more likely to be using imaging skills compared to their MPTs and BPT cohorts, counterparts, which is expected as well, right? When we went to the DPT, one of the big things we added in was imaging, clinical reasoning, things like that. We also found that physical therapists that were board certified were more likely to be utilizing imaging skills. People that are residency or fellowship trained were more likely to be using imaging skills. And then interestingly, PTs that were APTA members were also more likely to be utilizing imaging skills, which, that opens up a ton of questions. I mean, why are APTA members more likely to be using imaging skills? Is it that stronger PTs are by nature more likely to be joining the APTA, or are the members gaining some level of skills or some level of understanding of what jurisdictions are in regards to imaging by joining the APTA? But that was a surprising finding, to find that APTA members were significantly more likely to possess these skills than the non-APTA members.
Yeah, and it may just be that they're more involved as well. Like, they're just more informed about where the field is heading and what we need to be doing as clinicians. So, and there's definitely a lot more questions to ask than just those questions as well. I'm sure there's more diving that you can possibly do. And back to you're saying that you use case studies more often, and I think it's important to highlight that you're not really saying like case studies are more important than like randomized control trials. Just like in these scenarios where there's no randomized control trials, or maybe they're just the evidence isn't conclusive, these case studies can be insightful into being helpful and to perhaps steer you in a direction you wouldn't have thought of. And I think that's important to understand as well, that there's a lot of people out there doing good work, and perhaps they're asking questions that you wouldn't have thought of otherwise. And that's exactly what you're doing with your case studies.
Yeah. And I think, for me, I thought, okay, well, I'm going to put these out there. And, again, we were always told that case studies are the lowest form of evidence. And so I would put them out there, and I would expect them to have largely no impact. And then interestingly, what I found was, as I started traveling around the country a little bit, I started hearing from clinicians, oh, I read your cases, and your cases are good, and I use them, so these case studies do have an impact, and yeah, sure, for things that are common, right? So great, let's say for patellofemoral syndrome, there's lots of RCTs on patellofemoral syndrome, and there's lots of systematic reviews on how to treat these patients, and there's the the clinical practice guidelines, and okay, great. Let's say I follow all of those, and I do it exactly the way it's supposed to be, right? Well, those clinical practice guidelines don't get 100% of patients better. They get they tell you how to get the bulk of people better,
Right.
and what is that number? Is it 90%? Is it 95%? Is it 80%? Whatever that number is. Okay, I did all that, but now my patient isn't better. So
Now
now
what?
what? Right.
Yeah.
So, and that's when you have to look at, okay, well, it's not really what gets the 95% of patients better at that point. It's what, those 5% of patients that didn't get better, what gets them better. And that's when you start accessing some of the research on some of these more esoteric, niche little holes in case studies and things like that. And that's where they play a role. So I would encourage clinicians. I mean, if there are clinicians out there listening, you already have great cases. I mean, you can reach out to a mentor. I'm happy to mentor people where you can find somebody that you're familiar with that publishes. Reach out to a mentor and get those out there, because they're important to the literature, and they're important to clinicians, and they're used.
Very much so. And, you talked briefly that case studies can be super useful. And I guess other misconceptions about research that people don't understand, I guess, whether it's either at, like, starting the process of conducting research or anything that you've run into, because you've been a part of several publications, I think 31 or so. And so I guess, are there other misconceptions that you found while doing research?
Yeah, I think there are people out there that have interest potentially in dabbling into research. And I think that it's kind of like I don't know if there are any wine drinkers out there or non-wine drinkers, right? But drinking wine, it takes a little bit of time, right? Like, you don't start off with, I'll talk to people that, I don't like wine. I tried it once, and I'm like, what do you try? I tried a Merlot, and I'm like, well, I mean, that's probably pretty advanced for your first wine taste. Like, maybe you could start off at Riesling. Riesling's a semi-sweet wine, and you get used to that over time, and maybe you move up to a Pinot Grigio, which is a bit drier but doesn't have that oaky flavor, and and then over time you work your way up to the Merlots. You don't start at Merlot, and I think research is the same way. I think there are people that are out there that are interested in contributing to research, but they don't know what that would look like. They think they have to set up the IRB and do an RCT and things like that. And maybe it doesn't need to be that way. Maybe as a clinician, you can just start off with something small, like a case vignette or a case study, which doesn't require IRB, assuming it's retrospective. Or maybe as a clinician, you can get on board with, a senior researcher that's going to take the load of creating the IRB and creating the study and things like that. But you can plug in as a middle author, doing more of the execution end in the clinic. I know as an academic now, there are a lot of studies I would love to do, but I'm no longer really in the clinic primarily. So I don't have the capacity to do a lot of these clinical studies. But man, if I had a clinician that wanted to plug into me and say, hey, you can use my clinic for whatever numbers you need, just help me out with being a middle author, and I think that would be a great partnership. So essentially, I think that the misconceptions are, you don't have to start off at a Merlot. You don't have to start off at an RCT. You can plug in and you can contribute to something smaller, and then as you build your skill set, you can decide how far you want to go. And if you want to eventually, do your own RCT, you can. And if you don't, if you want to stop somewhere else, that's completely okay. I mean, I have. I don't think I'm quite at 30. I want to say I'm in the high 20s as far as publications, but I've never done an RCT, and I don't have one on the horizon immediately right now. So there's a lot of ways you can contribute that are a lesser hurdle than what I think people think of research to be.
Yeah. And then I think another message part of what you were talking about is connecting with other clinicians. And I think sometimes people can isolate themselves in thinking that they have to do everything by themselves. And I think it's really important that you connect with other clinicians that are doing something that you're not. So that way you can perhaps learn something, or at the very least, get a new perspective on something that you would not have thought of. Because even for me, doing travel and having done home health and outpatient home health, it's very easy for you to just stay in your own lane and figure out what, works for you. But then it's like, okay, now I start connecting with other people, and you're like, oh, like, I need to do this as a way to continue growing and continue getting better. And I think sometimes people can put themselves in a corner or in a black box and be like, nope, this is what I know. I don't want to know anything else. Don't talk to me. I'm good.
Yeah. Yeah, no, there's there's a great quote I have from a prior leader of mine, Colonel Crystal Henderson. She was my commander at Joint Base Andrews, and she said, get comfortable with being uncomfortable. And that has resonated with me, and that's stuck with me over the years. And if you think about growth, academically, clinically, anything else, growth happens when we're uncomfortable. And if we're comfortable, we're probably not growing. So doing something that's a little bit out of your comfort zone is completely okay, and learning from that. And again, even if case study seems like too big a hurdle, you can do something small like writing a poster. A poster is an abstract. It's 250 words. You put a poster together. There are people out there that have templates for you that can make it reasonably easy, and that will still go. Every poster that I've ever done is still on my CV, even now. So there are all sorts of ways that people can plug in, but yeah, people should be uncomfortable. If you want to grow as a clinician, be uncomfortable. So and what does that mean? Does that mean you're going to do research? Does that mean you're going to go get a board certification? Does that mean you're going to go do a residency? Does that mean you're going to be a clinical instructor? And maybe it might be a little bit uncomfortable for you to have, a new hotshot APT that has the latest and greatest research out there, but you know what? You're probably going to grow from it. And so there's a million different things that we can do to give back and contribute and grow. And ultimately, I think people should find out what that is and go do it.
Yeah. In addition to being a researcher, and you mentioned that you're also an instructor as well. And I guess, how have you grown as an instructor from the first time you started teaching to now?
Oh man. So I think that's an incredible question. So one thing I would say is, being a core faculty member, the responsibilities are a lot different than what they were as a clinician. So I looked at it as I'm a great clinician, and therefore that's going to set me up to be a great educator. And what I realized is, wow, like now that I'm in education, my clinical background is a fraction of what I do. There's service requirements for the APTA. There are not for the APTA. There are service requirements for the university that you can do, like working for the APTA or things like that. There's research requirements that are involved with that. You need to have a research agenda in order to be a core faculty member by CAPT. So that's the reason that you see a lot of programs will require board certification or fellowship training or terminal doctorate or things like that. As far as how I've grown as an educator, I think that I've grown a lot from the feedback I get from the students. We get feedback on every course, and I think that the growth happens not just from a content standpoint, where you're going in and changing the latest research or whatever else, but I think the growth also comes from a leadership standpoint, and understanding how to connect to students, and understanding how to manage different students with different personalities, and understanding that how you might manage one cohort of students might be different than how you manage a different cohort of students. I think that's been where my greatest growth has been over the last 3 years, is growing as a leader, and growing as a person, and growing as someone that has previously taught as a clinical instructor to a group of 1 or 2, where you can really tailor your approach to that 1 or 2 people, versus now trying to teach to an entire cohort, and instead making a presentation that's a little bit more palatable to a greater group of students. I think that's my greatest area of growth, and also the greatest area that I can improve in the future. That's something that I think I need to still strive to be better as a person and as a leader. And as I improve myself as a person and as a leader, I think that'll improve my connection to the students, and ultimately their education.
Yeah. And, how much is it being prepared, like research wise, versus being just like that leadership aspect that you're talking about? Because I can imagine early on, you're like, I want to be as like thorough, and I want to be as like diligent as possible with providing the best research or best information, and or maybe even the best treatment style. And I guess, is it more being prepared with information, or is it just having the confidence, and like you said, being a leader is what really makes it, being a teacher, like having people perceive what you're trying to give them better? Because you can know everything in the world, but if you're a terrible teacher, no one's going to understand what you're talking about. So I guess, what's your perspective on that?
Yeah, no, I think I think that's a great point, right? So I think everybody educates differently, and I think everybody leads differently, and I think that different approaches are welcome. And frankly, I think it's good for a program to have professors with different skill sets, so that it can, reach a different group of students in a different way, and everybody learns a little bit differently. So so I don't know if there's one that's better for the other. I know for me, leadership is important, and I think that my clinical acumen and my background in research has really helped me to create solid content. However, is it the single best content in the world? Maybe it is. But there's probably always areas for content to improve. But I think that the leadership end is important. I think that we can have students that or PTs that have the absolute most amount of knowledge in whatever given thing, but if they're not willing to run a clinic, if they're not willing to advocate for the profession, if they're not willing to, if they don't have the skills to connect to their patients, if, I think that we're looking more for a whole person as a physical therapist. And I think that, a lot of the education that occurs, at least at High Point University, a lot of the education that occurs doesn't necessarily happen in a classroom setting. There are opportunities to learn outside of the classroom through advocacy, through student participation and research opportunities and various other things. And frankly, those are the things that look great on a resume as well. I mean, when inevitably there are people out there that'll think, oh, well, I'm going to graduate with my doctorate and, that's going to set me up. And well, okay, sure. Like your doctorate is going to make you different than probably most of your friends and probably most of your family and probably most of the community. But now you're entering a profession where everybody's a doctor. So, that doctorate degree in itself doesn't get you too far. But, when you start doing things like, adding a poster presentation in there or contributing, in the, your state chapter student special interest group or various other things, now all of a sudden you become more of a whole person. And in that way, we're able to contribute more to our profession and more to our patients, which is important.
Yeah, I think human skills are what makes a clinician great, or anybody great. I mean, right? Like anything that you do, even like a normal physician or a lawyer, a lot of the time, yeah, you can be really, really good, but a lot of the time people's perception of you is way more important than what you actually know. And so if you can combine both those things, I think that's what you could turn yourself into a great clinician or great provider or whatever you want to do in life.
Yeah, I completely agree.
And what are some challenges? What was something challenging to you when you first started teaching that you noticed that you didn't expect? I guess I'm sure there's hurdles that you were like, I didn't expect this to be an issue, or maybe there was some hurdles early on that you had to get over. Maybe explain to me what perhaps teaching barriers you had to go through.
Yeah. So I think probably the biggest hurdle I found in my first year was there was a substantial cultural difference between military personnel. I was in the military for 20 years. There was a substantial difference between the military and the civilian sector, and what would work as far as a leadership skill in an 18-year-old airman is different than what's going to work for a 25-year-old doctoral student. They have different life experiences, they have different lived experiences, and culturally what we're doing is a lot different. So I think in some ways I fell on my face in some ways my first year teaching as I was adjusting to that cultural shift. And I think I've grown as an educator and as a person, and hopefully I have, because of the feedback I got from the students. And so for me, I think that was the biggest challenge is adjusting culturally. I think the other thing that's difficult in education that I wasn't really anticipating is the first year as you're building that curriculum. That is a rough first year. Those are long hours. Those are long days. That's, 7 days a week, late into the evenings as you're building that curriculum. Now the payout comes a little bit later. Once the curriculum is built, then the workload decreases, and now you have a little bit more free time to do other things like research or advocacy or things like that. But that first year, that was a rough year. So if people are looking at education, I think that they just need to prepare them for that. They need to prepare themselves for that first year being pretty brutal, and prepare their family for it. I don't think that I was mentally and emotionally ready for those hours my very first year. Nor do I think my family was prepared. Coming out of the military, I was already working crazy hours, and I thought that, coming to academia, I was going to be taking the foot off the gas a little bit. And if anything, that wasn't true that first year. If anything, I had to accelerate my first year while I was building the curriculum.
Very much so. And I think there's still a lot to be done, obviously, in the field of physical therapy. Where in academia do you feel that like PT school needs to improve upon? Is it the people skills that we're talking about? Do you feel like there's other things that we need to improve upon? Obviously, like maybe perhaps more imaging information. I know every school gets it, but perhaps more in depth, I guess, from your perspective, what are areas that we perhaps still need to improve upon in physical therapy school?
Well, I think physical therapy schools are probably a microcosm of our profession overall. So if you look at, where our profession was founded, we were founded as rehabilitation aides that were subservient to orthopedic surgeons. It was a certificate-based program that was completed, and orthopedic surgeons would, delegate whatever tasks needed to be done. And our profession not that long ago was one where the physician would tell us how often we were going to see the patient. They would tell us what treatments that we were going to do, and we would just do those treatments. So we really came from a foundation as technicians or as a modality, whether we want to embrace that or not. That's truly our foundation, right? Now we're moving away from that. And I think that, as we're starting to move away from that, we're seeing some friction of those that don't want us to move in that direction. There's still articles out right now that's talking about, physical therapists shouldn't diagnose. They should do a PT diagnosis, a movement diagnosis. And this is being said by physical therapists in big name physical therapy journals, that we shouldn't say things like ACL tear. Instead, we should use a movement diagnosis of, anterior translation dysfunction of the tibia on the femur instead of saying ACL tear. Frankly, that's ridiculous. That's going backwards, right? And if you look at another profession that has their own diagnostic names, chiropractic, chiropractic has subluxations, and no one else knows what that is, right? And that at least part of the reason for chiropractic being pushed into in some aspects being considered, alternative medicine, right? And I have the greatest respect for chiropractors. I think chiropractors are great, but I don't think we want to mirror that model and come up with these names that no one else in medicine uses. That's going to push us towards the alternative medicine. We need to be very comfortable with saying things like lumbar radiculopathy. We need to be very comfortable with saying things like carpal tunnel syndrome. We need to be very comfortable with saying things like ACL tear. Are these quote unquote medical diagnoses? Maybe not. I mean, I guess it depends on your definition. They are pathoanatomic diagnoses, and they are completely within our scope. So I think that one thing we need to get away from is this technician mindset in schools. I think we need to focus more on ownership. And then the other thing too is, I think as a profession, we're too focused on treatment. And, in reality, whether you give somebody a squat or a lunge or, a squat on a Bosu ball or whatever else, I mean, the gains that we're going to get and the differences we're going to get between those different techniques, sure, might one be better than the other depending on the patient? Absolutely. But we're talking about, a fraction of a percentage of better. And I think that where we can have a bigger impact in our patients' lives is if we spent a little bit less time focusing on improving our treatment techniques for that nth degree of improvement with the minutia, right? I think we should be great at treatment, but at some point the gains start diminishing, right? as far as getting education and treatment. But I think where we need to improve ourselves and where we have an area for great and dramatic improvement that will really impact our patients is from a patient management and ownership standpoint. So if I'm seeing a patient and if I'm going to refer them for imaging, let's say, I'm not just going to send them to the PCP and that's it. And that's what a lot of PTs out there are doing. Like if I'm in a system where I can't refer them directly for imaging, that's okay. I'm going to I'm going to contact the PCP. I'm going to tell them exactly what I want. I want radiographs. And here's why I want radiographs. And here are the views I want. This is a patient with a pivot and twist injury. So I want an AP lateral and tunnel view of the knee. And the reason I want the tunnel view is I want to be able to look at the intercondylar eminence to make sure that there is an avulsion there, which would completely change the treatment compared to an ACL tear. And then once I get the approval, I'm going to schedule a follow-up with that patient that we can review the imaging and continue care. So it's not I'm going to tap in the PCP like we're doing a tag team, and then I'm outside the ropes and I'm out. No, we're still in it. We still own that patient, right? Yeah. Now, once the MRI comes back and says it's an ACL tear, okay, then maybe I schedule them, maybe I refer them to orthopedics, whether it's through PCP or not, they're going to go see orthopedics, but maybe in the interim, I can work on some, quad strengthening. Maybe I can work on reducing the edema in the knee or the effusion. There are other things I can do until ultimately a decision is made that the patient wants surgery, right? Because maybe the patient will decide they don't want surgery. Right. Maybe that's their choice. Mm-hmm. But once I discharge them and once I pass them off and once I no longer have them, once I'm not owning this patient, now they're lost in the system, right? So now they choose no surgery, but they don't have any other physical therapy appointments. And now they just get lost in the system. Maybe they go home and get nothing, right? So I think that we need to take on more of an ownership standpoint as PTs. And I think that taking that and improving our management will have a greater impact on our patients than just doing one more therapeutic improvement continuing education course.
I always like to think,
I look at, there was one of the first studies I did, it was on a patient with an Achilles rupture. So it was done with John Tonarelli. He was a clinician, or still is a clinician in the Air Force, great researcher. And anyway, the patient had an Achilles rupture. And what I might see in a lot of civilian clinics is you identify the rupture, you refer to PCP, and that's it. And you never hear from the patient again. You never see the patient again. Now, again, we have a little bit of a scope difference in the military, but a lot of this can be done still in the civilian sector. We ordered the image. Again, you can do it in the civilian sector with the PCP. And then immediately after they got the X-ray, we had them come in and see us. And we did essentially a wet read where we looked at it and made sure, is there anything crazy? Like, are we seeing whatever else? The wet read we got from the radiologist was an Achilles rupture. So we were able to see that on the radiograph. Now, we already know it's an Achilles rupture. We knew that in clinic. Now we have the radiograph, which is the appropriate first step per the American College of Radiology for this. Now the radiograph has confirmed Achilles rupture, but they're still not going to cut this patient until the MRI shows where everything is. Where is the tendon? How much of it is torn, right? So now we need to, before we send them to orthopedics, now we want to get them the MRI, because the deal is if they go to orthopedics and they don't have the MRI, the orthopedic surgeon's going to say, thanks for coming, go get the MRI, right? Exactly, and that's another visit that clogs up the health system. And on top of it, that's another visit, the patient has a copay. So I get the patient, we do a wet read. It's still under their initial visit when they came in to see me earlier in the day. So there's no additional copay. At that point, I contact the radiologist and I say, hey, we have a patient with a confirmed Achilles rupture on X-ray. It's going to be important to get these patients in sooner than later for surgery before this scars down. So I know you guys are booked out for 3 weeks on MRI, but is there any chance we can get them in this week, right? So you use a little bit of political capital. The radiologist will say, hey, yeah, sure, get them in on Thursday. Okay, and that's what we did. So we got them in on whatever day it was. And then right after that call, I call up orthopedics and I said, hey, I have a patient here with an Achilles rupture. They have an MRI on Thursday. Can you see them on Friday? And at that point, once they show up to orthopedics, they're already going to have the x-ray, they're already going to have the MRI, they're going to show up to orthopedics, and then all orthopedics has to do at that point is determine, in conjunction with the patient, whether or not to cut, right?
Yep.
So we are essentially giving the case on a platter to orthopedics, and then all orthopedics has to decide is whether or not to cut, right? So in orthopedics, they call that the cut to consult ratio. The more times you do surgery as compared to the non-surgical treatments, the better the clinic will operate, right? So if we are able to present cases like that to physical therapy, to orthopedics, their cut to consult ratio is going to be better. But on top of that, that means that we get to keep the patients that are not surgical. But the second we just tap out and tap the PCP and step out of the system,
you lose
that hurts our patients.
Right. And that's what it's about, right? The patient. And I always think of physical therapy as like orthopedic liaisons for like the whole realm of just like almost primary care. Cause I can't tell you how many times I got in a patient who's not a wrong diagnosis, but just something that's not, whether it's like they have neck pain and it said like, I got a patient who has shoulder pain, or I have a patient who has knee pain and it ends up coming from their back or something. And, that whole idea of just being an advocate and saying, okay, I'm going to call this guy and make sure that they're going to get this. And like you said, putting it on a platter so it's as simple as humanly possible. One, the patient will appreciate it. And two, so will the orthopedic surgeon. And that's just generating a community of good communication and also it's just a great example of like how to handle patient care. And it needs to be done more often. Unfortunately, it's not.
Yeah, and I think the same holds true for PCP, right? So if we're going to, let's say, for instance, there is a subgroup of patients that will not get better from PT, right? Whatever that subgroup is.
Yeah.
And if there's anybody out there that's saying they get 100% of patients better, they're probably lying to themselves, right? Or they should go write some research and tell us how you're getting 100% of patients better. But in reality, you're not going to get 100% of patients better. Okay, so at that point, if they're not getting better, you're probably going to refer them back to the PCP. But we shouldn't just say patient didn't get better, figure it out, PCP, right? Because in reality, the PCP is not as well trained as we are in this, right? So you're tapping out and sending them to a respectfully lower level of care. And again, PCPs are better at what they do than we are, but we're better at what we do than they are. So if we are going to tap out at that point, we need to at least give some direction, right?
Yeah.
So okay, hey, this patient, isn't getting better with PT, but they're, a 50-year-old Caucasian overweight guy with knee effusion that's insidious in onset. Maybe it's gout. Like maybe we should be looking at an arthrocentesis and maybe a uric acid test or something like that. We should be able to have that conversation with the PCP. Now, granted, they're better at uric acid tests than we are, right? But we might be better at identifying gout than they are just because of what we do. So we should at least be able to have that conversation and give them at least some direction on where to go next. Similarly with imaging, one of the reasons that imaging needs to be in our hands is we have a very good feel for what's surgical or not, right? So okay, you have this patient with a little bit of degenerative disc disease. Okay, no big deal. That's something completely normal. That's probably not going to be surgerized, right? But in the hands of a primary care provider, they may or may not know, right? So that MRI comes back, it shows a little bit of degenerative disc disease, and now they're being sent off to neurosurgery. And then they get the neurosurgery, and neurosurgery is like, what? I'm not going to cut this, right? So what do? Well, then they send them to pain management, and now the patient's on narcotics and things like that. So, if we can shift that responsibility to us, and then we can have those conversations. Hey, listen, I worked with this patient for the last, 6-8 weeks for their back pain. MRI showing some degenerative changes, but there's nothing really on there that's surgical in nature. Clearly I've failed this patient, but maybe they need something different. So what does that mean? So, maybe they need a corticosteroid taper. Maybe they need a look from a chiropractor. Maybe they need a look from a physical therapist with a different treatment paradigm that they're doing grafts in or something else. But we should be contacting the PCP with those recommendations of, hey, this is what I recommend to do next to get the patient where they need to be.
Yeah. And do you think that physical therapy places it should be a placeholder for primary care at any point, or do you feel like it should be always primary to physical therapy?
Well, I don't think so. You're asking if all patients should go to physical therapy first before primary care. Yeah. So I think that it's always going to be a combination, right? So it's you because in order to get all patients to go to physical therapy first, you're going to not only have to educate the medical system, but then you're also going to have to educate every person that could possibly be a patient in your system, which is a substantially high hurdle,
Right.
especially if they've never been to PT before. So I think there's always going to be some level of combination between direct access and referred care. However, I don't think that getting patients through referred care really changes things a ton for us. I think that we can still be primary care providers, right? And when people hear primary care, the definition is always confusing. I've talked to many people, and some people think primary care means direct access. Some people primary care means first contact. Some people think primary care means expanded scope, like what we have in the military. Some people think it is advanced practice. Some people think it's actually working in a primary care clinic. If you actually talk to physicians about physical therapists being primary care, they don't understand what we're saying a lot of times, and they think that means we're going to be managing hypertension and diabetes, which is not where we're
Ridiculous.
going with this.
Yeah.
That's not what we're talking about, right? So there's a lot of different definitions out there, and there's a lot of confusion as I talk to people. And from my standpoint, primary care is about ownership. When that patient walks through my door, whether it is direct access, whether it is a referral or whatever else, I own them. I own everything about them. If they have cancer that wasn't caught, it's my responsibility to catch it. If they have an infection that wasn't caught, it's my responsibility to catch it. If they need imaging, it's my responsibility. If they might need additional pharmaceutical intervention, maybe I don't prescribe it, but it's certainly my role to contact the PCP and say things like, hey, what about a corticosteroid taper in this patient? Is that appropriate? And maybe it's not. If they're diabetic or something, maybe it's not, right? But that is certainly within my role to do that. So whether it's direct access or referral, I think that just coming from that ownership mindset that there is truly nobody in medicine better trained than what we are to do what we do. Orthopedics is not as well trained as us in conservative management of patients. They're not. They're much better trained at us at surgical intervention, right?
Mm-hmm.
Primary care is certainly not as well trained at us at any kind of orthopedic outcome. So we're the best trained people in the world, and we need to own that. And if you find yourself saying things like, I'm just a PT, you need to reflect on what that means and what you're saying to yourself and what you're saying to others when you say things like, I'm just a PT. And instead, we should be saying things like, I am a doctorally trained neuromusculoskeletal expert. I am the best at what I do in the health system, and I need to own that. And I think that would pay huge dividends with our patients.
Words are powerful, and I think that also needs to be. You talked about educating a lot of people, and I try to educate patients in that manner as well. Not as forceful, but just saying, and like, we know what we're doing. We know what we're talking about, and we know we're here for you to be an advocate, but we also are here to educate and bring you the best quality care, orthopedically, neuromuscularly speaking, as possible. And I think there's a lot of confusion. So I guess for people who are listening to this and they're like, okay, well, who should I see? A primary care doctor, or should I see a physical therapist? I guess discernible difference in my mind. I'm like, okay, if aches and pains, see a PT. Other than that, if it's something related to your heart or something else, go to primary. Would you use that as a way of kind of discerning between the two? Or I guess, what's your viewpoint?
Yeah, so I think that's reasonable. I mean, I think that's a reasonable discernment. I mean, the challenge is most patients aren't going to know whether or not their back pain is from something musculoskeletal or something non-musculoskeletal, right? However, if they come into something non-musculoskeletal, whether it be, a AAA or whether it be cancer or things like that, we are uniquely skilled to be able to screen that out, right? Yeah. So as a physical therapist, our first step should always be triage. does this patient belong to me? And this is true of whether or not they've been referred to you or not. The very first thing we should be figuring out is, does this patient belong to me? Is it something musculoskeletal? Is it not musculoskeletal? Should I treat this patient, or should I refer this patient while treating them, right? So for instance, in the case of the ACL I talked about earlier, yeah, I'm referring them on for imaging and I'm referring them on for orthopedics, but simultaneously I'm still doing some treatment stuff to kind of work on edema and whatever else. And truly, in the grand scheme of life, I'm doing that more to just make sure the patient is still plugged in. And I'm doing it more from a management standpoint necessarily than a treatment standpoint. But you can have that treat refer, or you can have the purely refer, right? This patient does not belong to me, right? And I had an interesting one. It was a patient that came in and he was 23 years old. And his primary complaint was ankle swelling, not pain, but just swelling. And he took off his boot, and it was atraumatic ankle swelling. And when he took off his boot, his ankle was purely effused. There was no edema; it was just an effusion. And I'm like, wow, I don't know anything orthopedic that would cause an acute onset of atraumatic ankle effusion in a 23-year-old.
Right.
I mean, there aren't a whole lot of orthopedic things that'll do that. So, at that point, I didn't know exactly what he was, but I knew he wasn't for me. He wasn't mine. So at that point, that was a pure refer, and I tapped his primary care provider and I said, look, I don't know what's going on with this guy, but I just know he doesn't belong to me. And so they ended up ordering an erythrocyte sedimentation rate, which is an inflammatory marker, which was off the charts. They ended up doing some more things, and what it turned out to be a gonococcal infection, which not a lot of people are aware, but when you get gonorrhea, the common location for it to go to is actually the ankle.
Oh, wow.
As a location. So that's what happened with this young guy. He had gonorrhea. It went to his ankle, and that's what kicked it all off. So ultimately, as physical therapists, at least in an outpatient orthopedic setting, which is probably outpatient orthopedics is probably the primary care of physical therapy, if we're really true. When you get into some of the specialties like pediatrics or neurology, at that point, it might already be clear that the patient has cerebral palsy or a stroke or whatever else. But orthopedics is a mixed bag. You never know what's going to come in on any given day. So from an orthopedic standpoint, if as a physical therapist you are treating every single patient that comes through your door, that should be concerning to you. That should be a red flag to you. You probably shouldn't be. There's probably someone that's coming in that doesn't belong to you, and you're treating them anyway. And that's that technician mindset, right? Or if you're treating everybody for 14 visits, right? That's probably a technician mindset, right? And that might be a great business model, but from a medical necessity standpoint, that doesn't make a ton of sense. So I think that I think that that's where we need to go as a profession.
Yeah, and humility. You got to have humility and understand that sometimes you can't treat every single patient, and sometimes you got to be able to reach out to somebody else who may know more than you. And I think that's a humbling thing to admit to yourself, and that's something that you have to experience in order to do so. But I think once you do that, it opens doors to understand like how the profession should be conducted, and realize that there's other options, and you're there for the patient. And so if you saw them for a month, 3 to 4 weeks, and things aren't getting better for, again, let's say insidious low back pain, again, maybe there's another clinician out there who knows what they're doing and are doing something different that you don't know, and you can learn from that. And that's super important. And I think having humility is a huge step in that direction.
Yeah, I think, as a provider overall, right? I mean, you look at, medical providers, and this is true across the board, right? Physicians, physical therapists, this is a group of people that have had exceptional amounts of success. They were very successful in high school. They were very successful in college. They go on, they get their doctorate degree. These are people that are used to getting, they get the 96% on the test, and they're like, why didn't I get a 97% on the test? This is the group of people that we're with, right? And I'm a pretty smart guy, but man, I'll go into a room at a meeting at the hospital. And I look around the room and I'm like, man, I might be the dumbest guy here right now. Like there's some
Yeah.
incredible talent in here. And, um, but all that being said, I think you take a group of people that's used to being right over the span of their life, a very high percentage of the time, and now you put them into patient care where the reality is substantially different. I mean, in the Moore et al. Study from 2005, non-orthopedic physicians were only accurate on their diagnosis 34% of the time. I mean, that's a shocking number. 2 out of 3 times they were wrong, right? Now, that was purely in orthopedic population, but still, I mean, that's a number that we need to wrap our heads around is, wow, like as clinicians, we're going to be wrong a lot, you know, and on top of that, physical therapists, I think physical therapists will right 75% of the time. So even still, that's 1 out of 4 times we were
wrong, yeah.
incorrect, you know, and
I think orthopedic surgeons were like 75 or 76. Like they were like just above
yeah,
us
it was,
or something like that.
yeah, they were just slightly above us. I think they were like 80%. We were at 76% or something like that. So, so even orthopedic surgeons are wrong 1 out of 5 times, right? So I think as medical professionals, if we want to really help the patients, we have to embrace the fact that we're going to be wrong, and we're going to be wrong a lot. And if we understand that, first of all, it helps us grow, because we can see it. Oh, wow, I was wrong on that, right? What can I learn from this? How can I grow on this? How can I change my treatment paradigm? Because if I think I'm right all the time, I'm never going to grow, you know?
Right.
So, so I think that's important for us, but it's also important if we understand that we're wrong, and we're wrong often, it helps us with humility with the patient that, you know, if things aren't improving, it helps us say, like maybe there's somebody else that can give this a second look and can give you better help, you know, because at the end of the day, it's not about you as a provider. It's always about the patient, and it's about their journey. And it's about them getting better. It's not about you being right. I would rather send a patient to someone else and they get better than me be right and patient stays with me and they don't get better. You know what I mean? Like we need to be able to say, hey, maybe I'm wrong here, and maybe I can tap out somebody else and get the patient where they need to be.
And I think this is great advice for clinicians, but also just for a patient perspective, it's important that, you know, your clinician can be wrong sometimes. And if you notice that your clinician is just trying to keep you on their schedule just for the simple fact that they want to get numbers in the door, you need to find somebody else. And if you do have somebody, or maybe a clinician who admits that they're wrong and they're willing to help you find that person, that may be somebody that you still want to stay in contact with. It doesn't mean that they don't know what they're doing. It's just that perhaps that, you know, at this moment in time, they're not able to help you. And that's somebody you can reference later down the road.
Yes, sir.
And so, you know, we talked so much about your career, and I think this is a great way to end the podcast here today. And I kind of want to just finish off with a couple final questions, if that's all right with you, to close out what would be a great podcast.
Yeah.
So first question, I asked this for everybody, so I'm going to ask you kind of a daunting question, but if you had the attention of everybody in the world for 30 seconds, what would you say?
Yeah, I think that's incredible. So I'd probably say something a little bit broader than physical therapy itself. But I think if my advice to people out there is, don't focus on all the reasons why you can't do something. Focus on all the reasons why you can do something. Right? I mean, for anything that you might pursue, there might be 100 reasons why it can't be done. But yet there might be 100 reasons why it can be done. And, you know, there's a great movie, Denzel Washington in the movie Antoine Fisher. And the movie, Denzel Washington's a provider. I think he's a psychologist. And he's mentoring this junior Navy seaman who's having some performance problems and things like that. So they're working together. And you know, further on towards the end of the movie, Denzel Washington encourages Antoine Fisher to pursue a college scholarship. And Antoine Fisher replies, oh, well, only certain kinds of people get those. And Denzel Washington replies, yeah, the certain kind of people that apply for them are the ones that get them. And I think that was such I even have chills just now saying that quote. It was such a powerful comment. And I think that if people just if they were willing to go outside their comfort zone, if they were willing to put themselves out there, if they were willing to say yes, and if they were willing to embrace all the reasons why they can do something, I think they'd be amazed at what they can accomplish. And I think that would resonate both with physical therapists, but certainly beyond, in a broader sense, if I had the attention of the entire world.
Yeah, I think everybody can definitely benefit from that kind of advice. It's very humbling and also just great advice. Second question, what are you most excited about next in your career or otherwise? I guess, are you looking forward to continuing teaching? Are you conducting more research? I guess, what are you excited for next?
Yeah, so well, I've been working on my PhD, so my research ventures have been getting a little bit more. Uh, they've been getting a little bit more detailed than what I started off with, being primarily case studies, which is fine. It's just a natural progression of me as a researcher. That's exciting, but I think probably the thing I'm excited about the most is some of the advocacy efforts we have going with the APTA. And frankly, my research kind of plugs into that, but I don't want to say too much, and I don't want to blow up any of the states right now, but there are a number of states that are working on advocacy efforts for diagnostic imaging. I know I was able to plug into North Carolina on their advocacy effort for spinal manipulation, and we were able to march on Raleigh and meet with our congressmen and our representatives, our senators and our representatives, and ultimately able to pass spinal manipulation a couple of years back in North Carolina. So I think we are at a really exciting flashpoint from an advocacy standpoint. And in order to get there, we're going to need numbers. When it comes to politics, we need numbers. So we need people at the very least to be APTA members, because those are the numbers we go to the politicians with. And, we have X number of members, and, this is who we're representing. And then once people are doing that, having them, be part of the Legislative Action Center. If you go to the APTA website and go to the Legislative Action Center, you can advocate for bills that are in Congress right now. And it's already set up for you. All you have to do is you have to click a button. They already have your congressmen, your senators in there. They already have the email written for you. You click a button, it sends it off, and you're able to support. If you're able to do more, there's adding into the Key Contact program. You can go to APTA and look up the Key Contact program. That's something I do, and I meet with Congressman Budd every year and talk about our current legislative initiatives. Congressman Budd, I think, is currently running for Senate in North Carolina to take over Senator Burr's spot, but he's also a representative for, I think it's District 13. And we've actually gotten, Congressman Budd has been a huge advocate for the physical therapy profession and has been a co-signer on a number of the bills that the APTA has sponsored. So we are making gains, and we're making gains all the time, every day. But those gains really need numbers to get there. And one example I'll give with that was a few years back, North Carolina was pushing for dry needling. And we thought we were going to be able to get dry needling just through going through the board, which is going through the state board is a substantially less challenging hurdle than going through legislation. And we went to the state board and we advocated for physical therapists to show up and support being able to get dry needling for the profession. And out of the 10,000 PTs in North Carolina, only 3 people showed up to the board for dry needling. Meanwhile, six acupuncturists showed up to the board. And because their voices were louder and more numerous than those in PT, the board ultimately decided not to allow PTs to get dry needling. Now, what that set up was that it ended up setting up a legislative battle, which ultimately led to a court battle. And, about, I want to say it was 8 years later, we ultimately got a Supreme Court ruling, a North Carolina Supreme Court ruling that allowed us to get dry needling. But think of all of the time and energy and money and everything else we could have saved. And we could have put that towards something else like reimbursement or whatever things are exciting different people. We could have put that time towards that if only more people would have shown up to support their chapter. So what I'll say is that we're doing great things in the APTA. We need numbers. We need your participation. I'm happy to help people on how they can plug into their state and how they can help. But But I think for me, that's the most exciting thing. We are at an absolute flashpoint, especially when it comes to diagnostic imaging in the United States. I think in the next 10 years, I think you're going to see the vast majority of states have some level of imaging referral for physical therapists.
Such great news. And any physical therapists out there listening right now, and get active and get involved with your state, and try to get as involved as you can, because even just being an APTA member is important. And so make sure to do that. So that's great advice, and I appreciate that. And last question: where can people learn from you, or at least know more about you, or get in contact with you if you so choose?
Yeah. So if people want to learn from me in the traditional sense of learning, I actually teach continuing education at Redefined Health Education. So I teach the diagnostic imaging curriculum. We actually have a couple of diagnostic imaging certifications where people can get certified in musculoskeletal imaging of the lower extremity or upper extremity or spine. And then if they end up getting certified in all three, they'll get what's called a master certification in musculoskeletal imaging. So that focuses primarily on static imaging modalities, so radiography, MRI, and to a lesser extent, CT scan and bone scan. So if people are looking to learn in the traditional sense, look me up on Redefined Health Education. If people are looking to connect me in other ways, I am active on LinkedIn. Feel free to contact me on there. Or if they'd rather send me an email, they can find me at lmabry@highpoint.edu.
Perfect. Lance, thank you so much for coming on the podcast. It's been great. So much great information. People can be able to take away both clinician and patient wise. So thanks.